Good evening, everyone. It's an absolute pleasure to be here with each one of you. And as Aarti put it so beautifully, I think the reason we are having this platform is to create that togetherness, to have that togetherness. And looking at everybody, I think we have, years and years of embryology experience collectively sitting here. So it's a privilege to be here with you and share a few thoughts on oocyte grading. Now, we all know that a great embryo, an embryo that is going to implant or has the potential to implant, a good quality embryo always comes from great gametes, viable, good quality gametes. So oocyte grading is one of the important steps in our laboratory to, which gives us additional information on the embryo, and especially because when we on day 3 or day 5 are actually selecting embryos, we are faced with different possibilities. Something like this where everything looks the same, everything looks so beautiful. What do you pick? How do you choose? So what we do is go back, track from where these embryos have come, look at the oocytes, see what link that we can get, and then pick those embryos coming from better quality oocytes to improve our implantation rates, to improve outcomes for our patients. Also, grading is important for us because it kind of tells us what went wrong in the laboratory, and very good troubleshooting is possible when you actually sit and give some time for oocyte grading in routine practice. Yes, it is controversial because it is a subjective assessment, and today we know that a lot of money, a lot of effort has been put in time lapse and so many other mechanisms that we use in the lab to improve our outcomes. But did it really make an impact? If we ask ourselves, even today, the simple grading that we do and link it with quality of embryo gives us much more information, much more faith that this cycle is going to work out for us compared to all other things put together. So the oocyte, when we start off, is a unique and highly specialized cell responsible for creating, activating, and controlling the embryonic genome, supporting basic processes like cellular homeostasis, metabolism, cell cycle progression to the early embryo stage. Now, it has a long history. From the ovary at the fetal stage, it is undergoing so much of changes there, through the postnatal period, through puberty, and during the periovulatory phase, where it is undergoing so many influences acting on it, the genetic background, the exposure to, whatever environmental changes, Ross generation, lifestyle, nutrition, hormonal homeostasis, and of course in the lab our culture conditions. So there are a lot of things working on this oocyte, and then we also know about the reserve. We are all aware that there is a lot of depletion that is happening, and age is one key factor that affects the quality, and it has been shown that as high as 65% of aneuploid oocytes are known to occur at the age of 41. So why does aneuploidy occur with age? If you look at the meiotic spindle, it is the chromosome distribution cytoskeletal structure present inside the oocyte, which accurately distributes the chromosomes to the cleaving blastomeres. Now, as the oocyte ages, this spindle undergoes certain changes. The length of the spindle increases, the tension of the microtubules drops, and there is premature chromosomal separation. And this is the key factor that causes aneuploidy in embryos. So just looking at some dysmorphisms which are known to occur because of the history of this entire, the oocyte, is enough to tell us how the embryos are going to form. Now, in nature, at the follicular level, what's happening every month in the menstrual cycle is, with the demise of the corpus luteum, the estrogens and progesterones are dropping, and that induces increased cyclical surges of the GnRH pulse, and that what happens is the FSH starts to rise, and that FSH crosses that critical threshold that is there and is staying there for a short time, enough to start a trajectory of all these antral follicles that are recruited. So some of these selected follicles take all that FSH and start producing the estrogen. Now, as the estrogen goes up, there is a drop in FSH, and that causes only a single follicle to move on, right? And because that follicle has some intra-ovarian factors which make it more sensitive to the FSH compared to the other follicles. So in nature, there's a very systematic, very meticulous growth of the oocyte and also cytoplasmic maturation that is happening inside. And by the time you get to ovulation, a lot of follicles have undergone atresia, and only the dominant follicle, which is growing in this environment, getting cytoplasmically mature, and with the LH surge, there is meiotic completion of meiosis and reduction of the chromosomes, where the egg is now ready to be fertilized. So IVF is very different, right? We are getting huge number of follicles to be growing in a uniform cohort. The sensitivity of some of these follicles to FSH varies from others, and therefore you have a kind of a cohort which is growing forward in this supraphysiological hormonal environment, which induces growth instead of atresia, and that allows maturation of oocytes with compromised quality. And that is why in our laboratories every day in and day out, we are faced with these kind of dysmorphisms. What are these dysmorphisms? Why do they occur? How much do we see? It has been shown in IVF that near 60% of M2 oocytes actually show dysmorphisms. Large number of studies, similar figures. We in the laboratory have seen at least about 40 to 50% of oocytes being dysmorphic, and sometimes the entire cohort is dysmorphic. I mean, all of you agree with me, there is a percentage of oocytes that can be dysmorphic. Sometimes the entire cohort is dysmorphic, and that shows that there are so many influences that are, working on the oocyte as it's growing, all the way from the vascularization of the follicle, the oxygen concentration inside the follicular fluid, the ATP, the cumulus cells, the interaction, the crosstalk, and several other parameters that the oocyte is getting exposed to during the IVF stimulation. Now, one thing to remember at the back of your mind is when there are severe dysmorphisms, these oocytes in nature in IVF don't fertilize very well. So nature somehow kind of takes care of that, because sperm binding, cytoskeletal competence, and sperm fusion to the plasma membrane, and also fertilization are all dependent on several cascades that have to go right. But whereas when we start doing ICSI, we're bypassing all this. So they do quite well, and therefore selection is important, grading is so important. Now, there are several groups that have used kind of grading systems grading them from severe dysmorphisms have been graded as -1, moderate, 0, and when there are no dysmorphisms, you can give a score like this. Gleischer's group does this routinely, and when they have graded dysmorphisms and separated the cohorts and then looked at the embryos, they found that at least you have a 3-fold rise in pregnancy and outcome if you select top quality embryos coming from better quality oocytes. So definitely oocyte grading has a role to play. Now, what is cytoplasmic maturation that is happening in that follicle? It's an extensive signaling of the oocyte to the theca cells, the granulosa, the cumulus cells, and the oocyte secreting microRNAs that are being released into the follicular compartment. So this cytoplasmic maturation starts off a lot of protein synthesis, modification of the proteins in the oocyte, and it's important to understand that those oocytes that fertilize and give you good embryos in the lab come from good cytoplasmic mature oocytes. What is oocyte aging then? In vivo or in vitro, aging can happen, and that causes a lot of molecular, cellular alterations in structures, misalignment of chromosomes and displacement of the meiotic spindle. So aging, cytoplasmic maturation, a critical balance between immaturity and overmaturity is very important for a top quality oocyte. And when you don't have this balance, because I told you some of the follicles are super sensitive, they grow, they give better quality oocytes, but some follicles are not so sensitive to the hormones that we are providing, and they may not be growing in an ideal environment. So dysmorphisms that you see under your microscope every day is because of either early in maturation or late in maturation. And if you have, one principle you should remember is, if you're early in maturation, you will end up with aneuploidies, and if you're late in maturation, you have a developmental failure. And this is the fundamental thing that we keep in mind. It's not something that you're visually seeing, but something that has happened in the follicle over time. So what's an ideal M2 oocyte? How does it look? It's round, clear, colorless ZP, a small perivitline space out here, right? A single non-fragmented polar body, a nice moderately granular cytoplasm with no inclusion. So this is the perfect oocyte with which every embryologist is extremely happy. And inside that cytoplasm is the meiotic spindle aligned with the metaphase plate aligned with the chromosomes, these two microtubular organizing centers, and a large amount of mitochondria. So this is what is an ideal oocyte. So when you look in your laboratory and you see the polar body, you see something like this, are you sure that this is a M2? Is it form to give or decondense the chromosomes? So looking at this, we know that it takes at least 2 hours for the establishment of the spindle after the decade of events in your lab. So therefore, there is a physical, the oocyte is sensitive to temperature and all the manipulations that we do in the lab, and even simple things like this can displace the spindle, and that is why it's important to be gentle and maintain pH, temperature, etc. in the laboratory. Now, when you look at morphological assessment of the oocyte, you're looking at the corona cumulus complex. You're also looking at the oocyte bare like this at the time of ICSI. So these are all the parameters you look at. And what is making this cumulus into that cloud-like appearance? It's because of the hyaluronic acid that is secreted by these cells, which goes and intersperses between these cumulus cells and kind of gives you that fluffy feel. And we grade the cumulus cells if they are tightly packed as a GV, if they are, you can't see the oocyte further packed like this below, we call it a immature oocyte. A nice pre-ovulatory oocyte has a nice radiating corona like this, these coronal cells, which you see the sunburst coronal appearance, and you see these gaps between the cumulus cells. That is nothing but the hyaluronic acid. So as the oocyte is getting mature, what happens is the cells start moving away, and therefore when you see a post-mature oocyte, you'll see even the corona disconnected from the oocyte, and you will see large clumps of dark cumulus cells to identify the post-mature oocyte. It's rare to see luteinized and atretic oocytes, but yes, this is how they look. The cumulus looks like this. And does really cumulus morphology help us? There are several reports that say that if you have a cohort of at least more than 50% mature cumulus complexes, the outcome in your laboratory will be really good. You will get good embryos, and therefore cumulus morphology is the initial assessment that you do. It helps you decide when to strip, what to do, and it definitely plays a role in predicting outcome. Now remember one thing, that when we see blood clots like this in the cumulus, our tendency is to cut them off and remove them. It has been shown that blood clots attached to the cumulus, something like this in this video, are associated with problems in that egg as it is undergoing maturation in the follicle. So whenever you see blood clots, try to separate out the oocytes and culture them separately, because Ebner's group has shown that the blastocyst formation rate of oocytes carrying blood clots in the cumulus is as low as 23% compared to 43% in normal cumulus complexes. So let's now look at oocyte dysmorphisms. We start off with the giant oocyte. It's very large, of course. You rarely see them, but when you see them, you need to remove them. You should not be working with them. The reason is they have two sets of chromosomes. And when they fertilize, they end up with digynic triploidy. Remember that in nature, these oocytes are sitting in that ovary, and it has been seen that the commonest, when you kind of look at the abortus material and you check, digyny is much more common in triploids than diandry. So what we used to think is, two sperms have gone in and you have, this thing, but in nature also it happens. So when you see giant oocytes, remember they have two sets of chromosomes. You should not be injecting them, and post-insemination you see them, you remove them. Now the shape of the oocyte. It's quite common to see, shapes like this. Of course, if your pressures are right and you see shapes like this, when you're doing your oocyte pickup, you're seeing ovoid oocytes, oblong oocytes. What can go wrong? The thing is that when we are looking at cleavage, we know that blastomeres cleave in that tetrahedral pattern. So if you have an oblong oocyte, obviously the space for the two cells is less, and then what happens is the pattern of cleavage becomes abnormal, and therefore you see these white dots here. Those are the cell-to-cell contact points. So the number of cell-to-cell contact points starts going down as cleavage increases. And as this happens, there is delay in compaction, because compaction is E-cadherin. It's communication. It's cell-to-cell contact. So what will happen is you'll have less compaction, delayed blastulation. So when you see abnormal shapes, think of, let's see, sometimes you see oocytes with no zona. So whatever happens in that, the zona actually protects these blastomeres, right, as the embryo keeps moving. So you should think of a situation which is very similar. You do get blasts, but definitely we see from this study that the blast conversion is less compared to normal, because of this reason is the compaction is delayed. Now let's look at some extra cytoplasmic anomalies. The polar body. Is there any role? Uri's group has said whether it's round, whether it's fragmented, whether it's irregular, whether it's oval, it really doesn't impact. It doesn't impact because he's the one who started polar body biopsy, so it really doesn't impact the embryo development. But if your polar body is fragmented completely, then the reason the polar body has fragmented is because you have kept that oocyte for a longer time in the laboratory, or in vivo the oocyte has aged, because fragmentation is associated with aging of the oocyte. And therefore, polar body morphology has nothing to do with the chromosomal situation of the gamete, but a large polar body or a fragmented polar body does not do well. A degenerated polar body definitely does not fertilize. So when you see oocytes like this with large polar bodies, you know that they are associated with multiple cytoskeletal and chromosomal anomalies, and these oocytes should not be injected or used, and they should be deselected. Does the zona pellucida have any role? We see a lot of dysmorphisms. We see lots of various shapes, thick zona, normal, thin zona, an enlarged septated zona, something like this, and a brown zona. So there was this study that came up with only brown oocytes. That means they compared normal oocytes to oocytes that were having thick zona, which were brown in color, with a large perivitelline space, and they really didn't find any major difference between the normal and such zonas, and the pregnancy rates and other things were normal. Now, it's one thing I must talk about when I'm talking about thick zona. The first thing that you think is these oocytes with thick zona may not do very well, because in IVF, because the sperm has to travel that further distance and go meet up with the oolemma. But this is not true, because oocytes with thick zona actually fare better with IVF, because nature knows how to do the job. In fact, it has been shown that when you do ICSI on oocytes with the thick zonas, you may be actually damaging abnormal oolemmal patterns which are associated with the thick zona, and maybe you are actually causing degeneration. So this was the outcome from the study. So Thin zonas, definitely higher fertilization rates. Increased inner layer thickness was, increased inner layer thickness was correlated with increased blastocyst conversion by Ramaraju's group and higher development. And variation in the thickness of zona was also associated with increased embryo quality. Zona bifringence, of course, Montag's group have shown us that if you have a pulsoscope, you use this and you can pick and predict better embryo quality when from those oocytes that have a good zona bifringence. Now, what about perivitelline space and the increased perivitelline space and the granules present in that space? Our own, Ashraf's group from Kraft have brought this beautiful paper where they looked at oocytes in the entire cohort. The entire cohort had increased perivitelline granules, and they compared them with normal, and that was a huge study, I think lasted for over 5 years. They compared 577 oocytes with 663 that were normal. So here was only increased granulations and no other dysmorphisms compared to normal oocytes, and they found that the FERT rate, the clinical pregnancy rate, as well as the live birth rate was lower in these oocytes. It probably is to do with oocyte aging and therefore probably problems with the spindle. So a perivitelline space, there are conflicting reports. If it's just increase, really no big deal. But if you have a lot of granulations, definitely there is lowered pregnancy rates and implantation rates like we saw. Perivitelline granulations are also said to be HMG dose dependent, so you can look back into your cycles and see the stimulation and kind of correlate. Now let's look at some intracytoplasmic anomalies. One thing to remember about the cytoplasm is it's not how much of abnormality that is there. I mean, it's not the size, but the number and the size that matters. So what is there doesn't play such a big role. Like you see in the top picture, you're seeing the refractile body, you're seeing a small vacuole, whereas the lower picture, you're seeing dark central granularity here and multiple vacuoles here. So the larger the problem, it is significant. If it's a small problem, it doesn't really play a big important role. So these are refractile bodies. They're called lipofuscin, and you see this kind of thing happening in our brain cells, in our neurons as we age. So it's probably related to aging of the oocytes, and it's actually a mixture of lipids and dense granules. And if it is more, if you see refractile bodies more than 5 microns, they are associated with lower fertilization and lower blastocyst development. So large lipofuscin bodies like this are associated with poor follicular development, lowered follicular vascularity, lowered oxygen saturation, more ROS generation and aging, and also they are known to occur more in PCO patients because of insulin resistance and abnormal lipid maturation in PCOS. So there has been an association with that. The large ones are definitely going to impact, so you can separate them out. The smaller ones can be ignored. So all of us have this, various terminologies that we use. The oocyte cytoplasm is dark, it's granular, maybe little dark, more granular. So many papers have many things. I've just put them here to tell you how each one of us use our own grading mechanisms. But the bottom line is that dark central granularity, it's a different thing altogether. The extent, this latest paper, 2019 paper, that shows that what they did was they looked at a cohort of oocytes with mild, grade 1, moderate, grade 2. You see this darkening here in the center, and large areas of extensive granulation. So this is associated with the immaturity of the cytoplasm, doesn't do well, and you know that grade 3 oocytes which are injected don't really give you a live birth. So if you see such kind of oocytes in the cohort, separate them out in the beginning itself, because you're not going to pick those embryos, and maybe you'll freeze them separate if they come out great. So what about vacuoles? Vacuoles are formed because of, they can be formed because of during the extrusion of the first polar body. They can be formed because of vesicles from the endoplasmic reticulum and the structures inside the cytoplasm, and they can also be generated by us doing the ICSI. The point is the vacuole fluid, the fluid that is there is the same that is present in the perivitelline space. It's the same composition. So what does this signify? It signifies that if you have a lot of vacuolation, if you're seeing something like this, there is a problem with endocytosis or exocytosis of the fluid into the PVS. Endocytosis or exocytosis, and therefore it is a defect with the oocyte, and therefore these oocytes don't do really very well. Now, fertilization rates definitely affected, especially because these vacuoles occupy large spaces, and the spindle, the movement, the microtubular network, the ICSI per se, all these create problems for us. Some vacuoles can continue into the embryo like this and definitely impairs implantation because of delayed blastulation again. Now, this is a dangerous one, the SER discs. All of us know about it. They look something like this. They are large accumulations of fat and the secretions from the SER. This is it's like a disc. It's not a vacuole. It's very different, and there is definitely lower blast generation because from when you get oocytes with SER, and it's probably gonadotropin dependent, related to high estrogens. Commonly seen in PCOS, and the fear is that there have been reports linking it to Beckwith-Wiedemann syndrome, where the child is mentally retarded with retinoblastoma, incidence of higher retinoblastoma, and multiple malformations. So the Eschre consensus, the alpha Eschre consensus, says that if you see SER aggregates in your oocytes, they should be separated, not be inseminated ideally. But it also says that if you only have them, then you counsel the couple and go forward, right? So that's about the SER. Now, the reason why central granularity and SER play such an important role is because they've looked at the spindle dynamics, and they've seen that these dysmorphisms have lot of alterations at the spindle level itself, and the metaphase plate itself is abnormal, and therefore at the chromosomal level we are going to have problems. So they also studied the number of displaced chromosomes from the plate, and they found that the incidence in these but the antag analog BMI PCO not so much linked to dysmorphisms. And summarizing the effect on fertilization, SER, abnormal vacuolation, larger sizes, large perivitline space and granules, and large polar bodies affect fertilization. The endpoints that affect the embryo quality are central granularity, dark cytoplasm, SER again, and overall oocyte score. We do not, with implantation, the overall oocyte score plays a big role. And of course, the refractile bodies, SER, central. So you can see that there are some common dysmorphisms that are alarming and should be removed in culture, because they play a role in fertilization, blastocyst formation, as well as implantation. Now, what about certain conditions like endometriosis? Why is it that oocytes with women who have endometriosis don't do so well, don't give us so many great embryos? The reason in this paper has been shown that these are the mitochondria in the oocytes with women with endometriosis. They are larger, they are vacuolated, they are abnormal, and you have less copies of them. So an average number of mitochondrial copies in a normal oocyte, if it is 1 lakh, here in endometriosis you will see them at around 20,000 or 50,000. So they have shown that the ovarian environment, the increased cytokines, and the diminished vascularity probably is the role playing a role in causing these problems at the mitochondria at the level of the oocyte. And so even if you look at the oocyte and say it's fairly okay, inseminate ICSI, the embryos don't really look so good, the cleavage problems are there because of the lack of mitochondria, right? So what about poor responders? You have less numbers, but the dysmorphisms are no different. So you fail and you do badly, not because of some new dysmorphism or some different dysmorphism that are there in these oocytes, but because you just have to work with these oocytes which have dysmorphisms. You have no other go. You have only 1 or 2 or maximum 3. So therefore you're transferring, there is no selection happening. You're transferring whatever you have, and that's why it's bad, but there is no real association between dysmorphisms and poor responders. Now, very rarely, of course, all of us have seen this. I've seen it, I think, more about 5 to 6 times in all my practice. You have GV arrest, and you increase the decapeptyl dose, or you increase your HCG, you give a dual trigger in the next cycle, you delay your oocyte pickup time. Still in the second cycle, again you'll get all oocytes at GVRS. So it's a genetic issue, it's an oocyte issue, it's a cell metabolism issue, and therefore such patients should be taken up for alternative gamete maybe a little earlier instead of repeated cycles. So this is more of a genetic issue, not a hormonal dependent thing. We've had this interesting case. We got, I think, something like 16 oocytes. When we looked at these cumulus complexes under the, the stereosome, you can see that I'm seeing a nice cumulus complex. I'm seeing something like a corona over here. But when I looked at it under higher magnifications, I didn't see a single oocyte. Can you see them? They're all empty. So it looks like there is a corona, but there is no oocyte inside. So such kind of variations, quite common. Atretic looking ooplasms, quite common. And most important for those of us, who are doing the ICSI, the degeneration that happens in immature eggs, especially in PCOs. We know that the plasma membrane, the characteristics are not really so good sometimes. I'm sorry. And when you go with your needle inside the oocyte, can you see this? There's no funneling at all here. The oocyte, you can go straight into the oocyte without any resistance. So such kind of oocytes don't do really well. There is immediate degeneration happening right under your eyes. So can we have the audience answering me, what's wrong with this oocyte? Go ahead. Perfect. What's about this? Right. Would you comment on anything else? Okay. What about this? Perfect. This one? Refractile body. What about this? Well, would you say large PVS, or will you say a shrunken oocyte? Right. What about this? Definitely shrunken. This one? Right. Multiple vacuoles and the smooth endoplasmic reticulum. There you go. You're done with oocyte morphology. So several papers there showing us the usefulness of this, the basic evaluation that we all do so quickly every day. And putting things together with the embryo morphology gives you better control. And so, in conclusion, I will say that till we get something more objective, like the mRNA analysis, the protein analysis, the microRNA analysis from the follicular fluid, the polar body biopsies, the proteomics, and the metabolomics, and etc., etc., etc. Till we get all these very advanced, things which are not yet affordable in routine practice, we are going to look at cytoplasmic maturity, oocyte nuclear maturity, the different the morphological appearance, and of course we are worried about the fact that we use so many hormones and recruit follicles, select follicles, dominate follicles that are not destined to grow, and maybe we're getting different stages of maturity, aged oocytes, immature oocytes, and the potential negative predictors like the dysmorphisms that we saw, and help us to score better, to identify cohorts better with higher development potential. Thank you.
తీసుకొస్తుంది మేడం తీసుకొస్తుంది